Good evening, everyone. My name is Debbie Hilbasell. Tonight is Tuesday, November 5th, and we are going to do case list review tonight. I just kind of scrolled through some of the attendees, some of the names I recognize, some I don't. So welcome to everyone who's listening. As for how to participate today, especially if any of you guys, this is your first webinar, most of you, although somehow called in on the telephone. Most of you are using your mic and speakers, and there's nothing that you need to do special. However, if you are using the telephone, if you click on telephone, you'll get a phone number, an access code, and a PIN. And I also forgot to talk about the little orange arrow up. It's on the left side of your control panel. It will basically just open and close your control panel if you need to. And then with regards to how to volunteer, you basically will just raise your hand and click on the little hand. Now, the one thing that sometimes happens is if you look up underneath your little orange arrow, there's a microphone. It should be green on your end to show that you're unmuted on your end, because I have everybody muted out, and then I'll go to unmute you when I go to call on you. The other thing too, there's a few more things I'm going to go over, but what I'm going to do right now is I'm going to lower everybody's hand. And the reason I'm lowering everybody's hand, I thank everyone for participating and for volunteering. But what I would like to do in order to give everyone an opportunity to have a chance to go who would like to go, if you've been called on in the last week, please don't volunteer until we've exhausted maybe other candidates who haven't been called on in the last week and would like to go. All right, so a couple other things. This is every once in a while, this has happened twice this year so far. With my internet, we have a streaming service. Occasionally, I have lost audio. If I lose audio, just stay on the webinar. I will phone in. I'll click on use telephone, and I will join you shortly. So hopefully it won't happen, but if it does, you know what to do. And then this is something, this was kind of just one of my little pearls. I was doing a mock oral the other day with a candidate, and she had a patient who I believe was like 23 G0 P0 and had like a high grade abnormality on her pap. She did colpo and colposcopy and ECC, and the colposcopy, I think, and the ECC came back CIN III. So she did a LEAP on the patient and then did an ECC afterwards. After doing the LEAP, the final pathology came back high grade dysplasia. And I'm trying to remember if the endocervical margin was positive. It might have been. And the ECC was, no, I think her margins were negative, which would made no sense. But post-LEAP ECC was positive for CIN III. And that's something we just don't see that often. So here's a young woman, P0, she did the LEAP. It did show high-grade dysplasia, but after the LEAP was removed, she did an ECC and still got back CIN III. So we were talking about how should you actually manage that? And I said, I know if the margins are positive on the LEAP, it's preferred to just do cytology and endocervical sampling. And so she said, no, I think it's even if the ECC is positive. And she was correct. It's just something I hadn't thought about in a long time. So I just wanted to go over this. So again, if you have CIN II III or CIN II III at the margins of a diagnostic excisional procedure or in an endocervical sampling obtained immediately after the procedure. And that was the part I was not familiar with. Reassessment using cytology testing with endocervical sampling at 4 to 6 months after treatment is preferred. So again, performing a repeat diagnostic excisional procedure is acceptable, but it's not preferred. Hysterectomy is acceptable if a repeat diagnostic procedure is not feasible. And then again, a repeat diagnostic excisional procedure or hysterectomy is acceptable for women who have persistent or recurrent high-grade dysplasia. We do know a positive margin or a positive ECC, post-procedure ECC, is a marker for increased risk of recurrence. However, it's the main factors for recurrence tend to be older age, large lesion size, and the grade of the CIN. And then even with a positive endocervical margin, 70 to 80% will be cured. And then again, just we know that if you have positive margins, the risk of persistence is higher. So that's my little pearl for the day. And then this, of course, just talks about follow-up for high-grade dysplasia. You're going to do co-testing. Let's say the margins were free. You're going to do co-testing at 12 and 24 months. If both of those are negative, then you're going to do retesting 3 years from then. So now you're out to basically 5 years, and then you can go to every 5 years. And then, of course, if any test is abnormal, you're going to do your colposcopy. You're going to, regardless of the age of the patient, go ahead and do your routine screening for at least 20 years. And that this, just remember this one, repeat treatment or hysterectomy based off of just a positive HPV test result is unacceptable, meaning that like say the PAP was normal or PAP was an ascus positive HPV, you did a colposcopy, found no pathology, but just HPV only. That in itself is not an acceptable reason to do a hysterectomy. All right, so now let's go to the volunteer. So we're going to go ahead and do case list review. So if you've been called on in the last week, I appreciate your volunteering, but let's see if we've got anyone else who would like to volunteer. Oh, I know what. All right. Farhio, let me just go here. I wanted to just talk to you for a second. Hey, you there?
Yes.
Okay. One of the things I wanted to go over, and I was still puzzled about your case from Sunday. So one of the things I would say is, if they ask you, tell me about this cervical laceration, just say it was the puncture site of the tenaculum. Because that's really all it was. Because again, a laceration, I'm thinking of a big tear through the cervix. So you could say at the site where the two-pronged tenaculum entered into the cervix, the lip of the cervix, that's what was bleeding. So it wasn't like there was some big extension. The other thing I want you to say is, I think the estimated blood loss was overestimated because her pre-op hemoglobin was 12, and didn't you say post-op was like 11.2?
Yes.
Okay, and so we know that basically about a 500 cc blood loss, and of course it's going to vary, will drop a hemoglobin about 1 point.
Okay.
So that makes me think it's a little bit less than that. Do you see what I'm saying?
Yes, I do.
Okay, all right, so good. All right, so that was the only thing I wanted to touch base with you with. Thank you. Okay, so that was, let's see here. Now, all right, let's go to Caitlin. Hey, Caitlin, how are you?
Yep.
Yep,
I'm good. How
you
are
there?
you?
I'm great.
Yep. Can you hear me?
Yep, I can hear you fine. Can you hear me? I need to
Yeah.
go out of, hang on. I got to get out of my PowerPoint. There we go. And then I've got to pull up the case list. Do you have a particular case list you would like to do?
I think
Caitlin?
office would be good.
All righty. Hang on one quick second. I'm just, one of the doctors was asking me if I was available to talk about a patient. Let me just quick text him back and said, I'm doing a webinar. Will be done. Okay, great. So office. So I just told them they can call me after. All right, let's pull something up. Do you have a particular case, Caitlin, or you just want to we'll just grab one?
I guess just anything that sticks out to you that could be useful.
You betcha. And there we are. So how'd your day go at work?
Oh, pretty good. It was a little busy. It's raining here, so I thought it would mean there'd be no shows, but there wasn't.
Yeah, they're bored. They wanted, let's see here. So I'm just trying to look through here to see something. Wow, this one's a pretty interesting one. Well,
I'm
let me
pretty
just see if I
wordy
can find.
on my office.
Well, again, I think it's really hard not to be.
Yeah.
All right, let's look at patient number 16. So this one's interesting. So she's been using combined OCPs and she came in to see you and she's 57 and still on OCPs.
Yeah, that's correct. Yeah.
Okay, so were you prescribing these for her?
No, I was not. I sort of inherited this patient from one of my senior practice partners. So
Okay, in general, if you have a patient who's pretty, active, healthy, etc., is there a certain age that you would recommend discontinuing OCPs?
typically I would discontinue around average age of menopause, so age 51 or 52 is when I would think about discontinuation.
Okay, what would be so let's say you had a patient who was 51 or 52 and you said, I'm not really comfortable with you using estrogen containing OCPs for much longer. Why? What's the risk of being on an estrogen containing OCP?
You worry that they could be at risk of VTE, pulmonary embolism, stroke. Those are the biggest risks, I guess. DVTs, things like that, for the most
No, you're
part.
I agree 100%. So it's the VTE risk, which increases in all of us as we age, and then is compounded with estrogen, oral estrogen in the OCP. And we worry about stroke, and we even worry about it in our young patients. It may not occur very frequently, but a stroke is a pretty catastrophic side effect that can occur. All right, so she's coming into you, she's on OCPs, and she is already having hot flashes and fatigue.
Yep, she was
Okay.
complaining of those things to me. Yeah.
Was she having monthly menses? Was she just having those hot flashes during the placebo week?
She was really just having that. She was actually having the hot flashes all the time and fatigue, and so she wanted to stop the birth control pills, but was trying to figure out what could be done, about her hot flashes. They seemed to be worse during the placebo week, so I think she kind of related that to being when she didn't get the estrogen. So
Okay. And so what did you tell her about the average age of menopause?
I did tell her the average age is 51, and usually that there are people who can go into menopause kind of 5 years on either end of that. So 50, 47, essentially to close to where she was right now at 57.
Okay.
And that it was possible that she was menopausal.
Okay. So with regards to her being 57, she was probably still having monthly menses because of the OCP. Was she concerned
Right.
about pregnancy, or did you want to just prove to her that her FSH was elevated? I guess I'm just trying to figure out
Yeah,
how
she
did
actually
your
asked for those labs. Yeah, so she actually asked for those labs to be drawn, or she said, how do you know for sure that I'm not going to get pregnant? And I was like, there's no, I guess, no 100% way to know, short of you stopping the pill and we see if you're still cycling. But during that like month or two while we were figuring out if she cycled, she really wanted to know that she was in fact menopausal. And so we talked about, potential labs that could be drawn, if they were, and I said, there wouldn't be much utility in them unless the FSH was extremely high. Although it does fluctuate. I did counsel her on that. And she still wished to have them drawn just for like reassurance.
Okay, perfect. So did you really need to do an LH?
I did
If
not
you're,
need to.
yeah. So
Yeah.
I was going to say, I'm just trying to look at things the examiners would ask you. So, okay, if you really felt
Right.
like you needed to do it, would an FSH by itself just been good enough? Did you really need the LH, and did you even need the
Right. It
estradiol?
could have been right. FSH would have been fine, if
Okay,
anything at all. Yeah.
all right. What were the other
So how do
fatigue
I
labs? Go ahead, go ahead, go ahead. Tell me what you're going to
um
say.
oh, the remaining fatigue labs that I typically draw are just TSH labs. I might look at a vitamin B level. Um Sometimes I'll do that. In her case, I don't remember specifically what we did, but I know that there was nothing specific for her fatigue that showed up on labs. So.
Okay, so let's just stop there. So in general, what sort of things could cause fatigue? Thyroid dysfunction. What else?
She could have anemia, so like a
Yeah,
CBC
okay.
might have been
Yeah,
helpful.
even if
Yeah.
she's not having heavy menses, maybe she's got a slowly bleeding gastric ulcer, or she's losing blood from
Mm-hmm.
her colon. She forgot to tell you her stool's black, tarry, and sticky. You know what I mean? So absolutely,
Mm-hmm.
57-year-old, I would have done a TSH and a CBC as a minimum to look at fatigue. And like you said, if you wanted to check, I think I would just leave it at that, Caitlin. I would just say you did a
Okay.
TSH and C. I don't know that I'd get into the B12 levels or like vitamin D levels or anything like that. I think it would be good enough for the test to say that. All right, so then if they said, why did you do
Okay.
all those tests? You could just say, this patient was absolutely adamant that I get this is what I would say. I would say I recommended that the most we would need to get would be an FSH, but she was adamant that she wanted her estrogen level done too. And if they said, why did you also get the
Mm-hmm.
LH? Just say the lab reflex to it or something. Or you can just say this was
Okay.
all ordered, but if this patient came in to see me again today, the most I would do would be a FSH. That's all. And that's fine.
Right. Okay.
Okay.
Yeah, that makes
So
sense.
anyway, so now you indeed show that she is menopausal. You can't really call her postmenopausal yet because you don't really. I would
Mm-hmm.
assume she would be. But anyway, so she stops her birth control pill, and did you immediately put her on the patch?
In this case, we like that is one of the things that I did do. Yeah, I only saw her for this one visit, because she had been kind of, like I said, seeing my other partner. But we did stop her birth control and start the Climera Pro patches and told her to use condoms as a backup for
So if
one
she's
year.
taking birth control pills, which are actually higher doses of hormones, how's the combination
Mm-hmm.
patch going to help her with vasomotor symptoms?
Um, I don't really have a good answer for that
I don't know
one.
that I
I
do
just,
either, but here's what I would say. I don't know that I have a good answer either, but a couple of different things. Number one, with the birth control pill, she's taken it for 21 days and then not for 7 days. It's a synthetic estrogen. She's taken ethinyl estradiol. With the patch, you're actually giving her
mhm.
estradiol, right? So you're giving her a much lower dose, but you're basically giving her um, uh, true
Continuous.
estradiol. Yeah, exactly, and
Okay.
continuous. And have you seen her back since? Is she doing better?
She is
Than,
doing better, but mainly again she follows with my partner. But yeah, she's doing better with that.
okay, so
It's been
that's
a year, so she stopped condoms and stuff.
okay. Yeah, so because sometimes we can use birth control pills in the perimenopausal woman, right? So they'll come in, they can start having hot flashes 6, 7 years before they stop menstruating. Oftentimes it will be night sweats, but they'll come in with irregular cycles, some hot flashes once in a while, and those patients are great candidates for a low dose OCP to help get them to the menopause. So what's kind of interesting is why she felt so crummy on OCP, because you would think that would help with her vasomotor symptoms, but again, she wasn't on it continuous, and she's on a synthetic progestin and a synthetic estrogen, where if you've given her basically, what'd you do, put her on the combi patch? Probably.
Mm-hmm.
Yeah, so
Mm-hmm.
so
Yeah.
she's got estradiol and what is it, norethindrone? I can't remember right now the progesterone on the
I
patch.
think it's north. I need to look at that.
Yeah,
Yeah.
I think
Yeah.
it's norethindrone too, but double check that. Okay, so then basically our hopes is that she will be fine. So ACOG says that we can continue to give OCPs up to age 55 if the patient is totally healthy and has no contraindications, but they do not recommend giving it past that. What do you
Mm-hmm.
counsel her? Now she's 57, horrible vasomotor symptoms. How long are you going to keep her on these on hormones?
I would just take her through till the symptoms sort of started to resolve on their own. So it's like just as long as she has the symptoms, I think she can be on hormone replacement therapy. So if it continues to be a problem in a few years, I would say on average probably 2 to 3 years. I would hope that they would improve. But if we did a trial of like a drug holiday and they did not improve, I might leave her on it.
Okay, so do you have any idea when somebody stops their hormone replacement therapy, do you know what percentage of patients will actually get a recurrence of their vasomotor symptoms?
I do not. I would guess like 20%, but I don't really know.
I've read 50% that half of them will, but that also means half of them don't. So it's reasonable on an annual basis to at like kind of like at every annual exam, review with the patient, okay, you're on your hormones. Do you wish to stay on them? Would you like to try coming off them and see how you're doing, etc.? And if 50% can come off and do fine, well, great. And if they have a recurrence of vasomotor symptoms, there's no reason that you can't put them back on. What are you going to tell her are the risks of HRT?
I would tell her there is a slight risk of I guess breast cancer, slightly increased risk of endometrial cancer, although she is getting the progesterone with that, so that kind of negates
Mhm.
that risk.
That would negate that. Mhm.
Because she's still getting hormones, it's a lower risk than a birth control pill, but there is still a slight risk of VTE with this too.
What about with the estrogen
Um,
patch? Do you tell her anything about the transdermal patch? Does that have a lesser risk, greater risk, no difference than oral
it has a lesser
hormone
risk if it's
therapy?
transdermal than if it were
Okay,
oral. Yeah. Hmm.
okay, do you know why?
Because of the metabolism is different, I believe, but I'm not sure why.
Okay, so yeah, so let's briefly talk about that. So one of the main risks of hormone replacement therapy is VTE risk, right? And so we know
Hmm.
oral estrogen does that first pass through the liver, increases the coagulation factors by going through the liver, increases the VTE risk. By doing transdermal estrogen, it doesn't do first pass through the liver. So you avoid that increase in coagulation factors. And actually, studies have shown that the incidence of VTE is no different than placebo with the transdermal
Oh, great.
estrogen. So we can
Okay.
really help to decrease that. What are you going to tell her about breast cancer?
It's a very low risk, but if she had like a personal history of breast cancer, that's something that we would, recommend against being on hormone replacement therapy unless she had unless she had spoken to her oncologist.
Okay.
But if she
Um,
does not have a personal history, then it is considered overall safe.
Yeah, it increases it, but it is exceedingly small risk. And so anytime you tell somebody, well, by taking this, it increases your risk of breast cancer, most women are going to get totally freaked out by that. So they do say it's really important that we try to help quantitate it and more put it in absolute risk reduction for our patients. So for instance, we know the WHI showed that after 5 years of usage of estrogen and progesterone, there were 9 additional cases of breast cancer over 10,000 women years over for 5 years. So if you took 10,000 women, put them all on hormones for 5 years, there were 9 additional cases of breast cancer than if they weren't on it. So per person, that calculates to like 0.0009% or something like that. So it is much less, you've got your baseline risk, but we're going to increase that
Mhm.
baseline risk by way less than 1%. And the North American
Okay.
Menopause Society, I think, actually does a really nice job in their position statement from 2017. They said we should tell our patients that if they take hormone replacement therapy, it increases their risk of breast cancer about the same as if they drink 4 ounces of wine per day, or if they're
Okay.
overweight or obese, or if they don't exercise. So any one of those lifestyle choices increases their risk just the same as hormone does. And I think that really helps to kind of quantitate it. What does hormones do to cardiovascular disease? Increase it,
It
decrease it,
does
no
have
change.
slightly oh, sorry.
What, increase it,
I
decrease
think
it,
it's
no change.
slightly decreased, I think, risk of cardiovascular.
Kind of, maybe. Okay, so here's the thing. You are right. We know it doesn't increase heart attacks. The whole reason
Mhm.
for the WHI was to see if it would decrease it. So in these young patients who are less than 60 when they start their hormones and are less than 10 years postmenopausal, we can tell them that they are not increasing their risk of cardiovascular disease by taking these hormones for, say, you know, 10 years or whatever. What we are not supposed to tell them is that it probably actually decreases their risk, although that's what the studies
Okay.
have tend to be showing. But they said as a minimum, we can tell them it is not going to increase your risk. And the only thing that they
Okay.
showed in the WHI was increased risk of stroke, but that was primarily in the women who were over 65 when they started oral estrogen, the oral hormones.
Okay.
Okay, good. So that was oh, I see you put her on Climera Pro. It was right there. I didn't even look at that. Why condoms
Oh,
for a
that's
year as a precaution? That her
That
FSH
was
was
that was a suggestion by my partner because of her just extreme anxiety about, like,
okay.
again, if she was menopausal, are you sure I won't get
Okay.
pregnant? That kind of
Okay.
thing. So
Yeah. So if
yeah.
they ask you about that, like, really, you can say that truly was done to address patient anxiety, that we told her it was
Hmm.
not necessary to prevent conception, but she was adamant, she really had a fear of pregnancy. So,
Right. Yeah, she
okay,
did.
good. All right. Well, yeah, so that was kind of a good one because it was just kind of a weird mishmash of stuff. So any questions on that?
I know it's weird.
All
I
right.
don't
Thanks.
think
Mhm.
so. Just mentioning all that. So thank you.
Okay, thanks, Caitlin. All right. All right, Lauren, I'll come back to you, but I want to get Sarah was in here first. Hey, Sarah, how are you?
I am good, thank you. How are you?
Good. Are you a general OBGYN?
Yes, I am.
Okay, and what case list would you like to do?
Um, I don't have a preference. Maybe office as well.
Okay, all right. Let's, because office is a weird one, isn't it? There's
Uh-huh.
just such a bizarre mishmash of stuff that you can ask. And, you know,
Mhm.
I know I did a mock oral today on a candidate. And here's the thing, because we can choose which patients, we put down. So
Mhm.
this person had listed, oh, on the case list, she had somebody come in for preconceptual counseling who had Crohn's disease, who had an ostomy, who had lupus. And I was like, oh my gosh, why did you pick this one to put down? So I'm like, okay. And so she started laughing. I'm like, okay, so now what? I mean, how does an ostomy affect pregnancy? How does pregnancy affect an ostomy, Crohn's disease, lupus? I mean, and she was prepared. She had gone through it all, but I was kind of like, really? Out of all your patients, you picked that one, but at least she knew what to look up. So that was that was the good thing. Any
Yeah.
particular cases that you can think of on here?
No, nothing in particular. I remember when I first started my case list, I did the same thing. I put interesting things and then I decided to get rid of those. Oh, you know what's a good
Yeah,
one, actually? Maybe this, the catamenial pneumothoraces. So she's got thoracic endometriosis. You just scrolled past it.
yeah, I saw it. I saw it
There it is,
somewhere
13,
because I
case 13.
13, 13. Okay, so here's a 37-year-old G0P0. So how often was this actually occurring?
So this is a 37-year-old patient who came to me with monthly catamenial pneumothoraces, and actually had a history in her 20s of a hysterectomy and a unilateral oophorectomy. So she had one remaining ovary, but had confirmed endometriosis, in the thoracic.
Okay, so I'm going to back
Area.
up. So she had a hysterectomy and an ovary removed back in her 20s.
Years ago, yes.
Okay, years ago. Was she having pneumothoraces then, or
Yes,
this what she really was?
she was. Yeah.
Okay, so they're assuming what? There's endometriosis all through her body, including in her
Mhm.
lungs.
Yeah, and
So what?
she had an endoscopy procedure, or I forget exactly, but ultimately there is pathology to confirm it.
So was she when she presented with this with
Mhm.
you?
Mhm.
This biopsy proving thoracic endometriosis? That was from back then. You didn't repeat it again, did you?
That had been relative, that wasn't incredibly old pathology, but no, I did
Okay.
not repeat the pathology. We took that pathology. She came to me because she had been on Depo-Provera, but was still having cyclic chest pain
Oh my
on the
God.
Depo-Provera. Yes, but
So
she had. Mhm.
when she got these pneumothoraces, how were they treated?
um, decompression, or I think just needle decompression. She'd be hospitalized every so often, and it was significantly impacting her life. But she's a very, very nice, well-adjusted person with this
Holy
unfortunate
cow.
circumstance. Very reasonable.
So,
It's not your typical, patient with endometriosis and chronic pain. It's just, I think that had been an issue for her. But she had this residual ovary and was still, despite Depo suppression, having cyclical chest pain. So when she came to me, we discussed the options.
which
Um,
were what? What
uh,
options did you offer her?
well, so, we discussed Depo, continuous cyclic uh, combined hormonal contraceptive pills, which she had tried in the past, I believe. And I have to go back and look, more in depth at her history in case, in preparation. But ultimately, we arrived at actually putting her on Lupron. So I now have her on long-term Lupron therapy with add-back.
And okay, oh, all right. So then what do you mean? And so how is she doing with that?
She's doing excellent on it.
No further
Nothing.
pneumothoraces, no further chest pain or anything. All right,
No.
so how long are you going to keep her on this?
So I figure I'm going to get this question, and ultimately my plan is indefinitely. I don't have an alternative plan. And, potentially, I guess you could do it for, it's actually been almost a year now, and she's had such good relief with it. We could give her a break, and go back to something more like Depo with less long-term side effects. But ultimately, she's very satisfied with the Lupron.
And what add back therapy are you giving her?
She's on 5 milligrams of norethindrone,
Okay.
and
How was
I
she?
believe she takes it cyclically.
Okay. Really? She's not doing it daily?
I can't
That
remember. I
doesn't,
have to look. Yeah,
I bet
I
you she's
can't remember.
taking it daily.
I might have her on it daily or 14 days a month. I can't quite remember. I'd have to look back.
Because really, what's the purpose of add back therapy?
To mitigate symptoms associated with Lupron, the vasomotor symptoms, but also to prevent bone
Right. So
resorption.
I bet, so I would just say she's on it
Daily.
daily.
Okay.
Yeah, because that would make the
I,
most sense for symptom and bone protection.
she might be on it. I have to double check. Yep.
Okay, so then let's go back to this. Do we have any, oh, are you doing, if the goal is you may have to have her on this for quote forever, are you
Mhm.
going to start doing DEXA scans on her?
Yeah, that's a good question. So potentially she does have risk factors for early onset osteopenia and osteoporosis. She's currently young at the age of 37. Um, I suppose I could use the frax calculator to determine what her risk of
I
osteoporosis would
think,
be.
don't we
Mhm.
say we're supposed to use that in 40 and over though? Isn't it indicate, I think it's approved for 40 and
40 and
over
over. I
for
think
some
you're right.
reason.
Okay.
Frax is.
I
So
could see
here's what,
this conversation going down that direction.
absolutely. So here's what you could do is you could
Uh-huh.
say, I have her on Depolupron, 5
Mhm.
milligrams a day of norethindrone for add-back therapy for symptom control as well as bone protection. She's on calcium. She's on
And vitamin
vitamin
D.
D. She's
Mhm.
doing regular weight-bearing exercise.
Mhm.
And
Okay.
like, have you talked to her about an art to? And here's what. Let me go back on the DEXA thing. And that
Mhm.
the goal is that you're going to get a baseline DEXA at age 40. Just say that
Okay.
because you probably
Okay.
wouldn't put her on a bisphosphonate yet anyway, but that your goal
Right.
is you're hoping the add back therapy and all that will take care of it. And you're hoping that your plan is to do a DEXA at age 40 unless
Mhm.
something would change. Okay.
Okay.
Now,
Okay.
have you talked to REI about her, about what their thoughts would be about long-term treatment with a
No,
with Depolupron?
I have not.
Okay.
Mhm.
It's just something to think about because,
Yeah.
one of the other things too that they looked at when we looked at long-term therapy and we did add back with norethindrone, there were
Mhm.
some studies that even added back really low dose oral estrogen as well
Mhm.
as um, the norethindrone.
Different.
So I'm not even saying, I mean, at this point in time, her vagina is okay. She's not having significant vulvovaginal atrophy or anything like that.
No. Mm-mm.
Okay. At any point in time, would it ever make sense to just go take out that other ovary and just put her on, if you just took out
Yeah.
the other
That's a good.
ovary and then you just put her on norethindrone, I mean,
Right.
wouldn't that kind of be the same thing?
Yeah, it's an interesting thought. So, I think it would just be a discussion with the patient on the risks and benefits of continuing the Depo-Lupron versus, an early age oophorectomy.
So here's what you could say, that the goal is to put her on this for at least a year to see if it truly made a difference.
Mhm. Okay.
And then if it really did make a difference, she really felt great,
Mhm.
she wasn't having any more pneumothoraces, etc., then you could talk to her about the benefit of taking out that other ovary. Then she
Yeah.
wouldn't need Depo-Lupron anymore. She'd be in a surgical menopause and you would keep her on the norethindrone. But
Right.
you discussed wanting to do this for at least a year,
Mhm.
maybe even 2 years before you, I don't
Okay.
mean to say doomed her, but you know what I'm
Uh-huh.
saying, to a
Yeah.
surgical menopause.
Right. Because this is essentially a life-threatening complication related to severe endometriosis. So,
Absolutely. Rather than
um,
have her do the expense and the all that stuff of Depo-Lupron, by taking out her ovary, you'd do the same thing.
mhm, mhm.
And you could
Okay.
just keep her on. But you wanted to do it long enough to see that it did indeed um, accomplish what
And
you hoped it would accomplish.
yep. And so then for endometriosis, I know there's, the overall recommendation would be for a hysterectomy with or without ovarian conservation is another
Mm-hmm.
discussion.
Mm-hmm.
And overall, I've seen kind of conflicting, um, I've read conflicting things, be it either the practice bulletin or in the prologues, where they'll say if you remove the ovaries, I'm sorry, if you leave the ovaries, some I've seen it's as low as 10% or as high as 60% in terms of recurrence and then the need for reoperation.
Okay, I'll tell you what I recall from
Okay.
basically reading the most recent the practice
Mhm,
bulletin on endometriosis. So back in my day, when we were, you did definitive surgery for endometriosis, even if the patient was
mhm,
37, chronic pelvic pain, failed all
mhm,
therapy. You know, if
mhm,
you didn't take out everything, including her ovaries, you would have been basically chastised for not doing a complete, like, what did you
mhm,
do? You did a partial help of
mhm.
this patient. We were so bad back in those days, we actually then made patients go 6 months without any hormones at all, thinking that
Wow.
killed off the endometriosis. So we were taking these
Mhm.
young women, making them surgical menopause, and then not giving them hormones for 6 months. All right, so
Mhm,
that was the thought back in those days. All right, so now what the ACOG practice bulletin says is, with endometriosis, when you go in to do definitive surgery, if one or both of the ovaries looks 100% normal, there's no dots of endometriosis, they've never had an endometrioma, there's no adhesions, there's no anything, you can make an argument for leaving one or both as long as the patient understands she has about a 33% chance that you're going to have to go back in and reoperate and remove those ovaries. And they don't really say why. They don't say if it's because of recurrence or just ovarian pain or endometrioma, but that's kind of the one that I use is
okay.
um, uh, that about a 33% chance for reoperation.
33% chance. Okay.
Hmm. So good. No, that one's very interesting. But the bottom line is endometriosis is medical therapy. Once the patient has had the diagnosis, then we just try to manage it medically as best we can.
Okay.
All
Thank you.
right. Thanks, Sarah. That was very interesting. Thanks. All right, let me go find Lauren. Let's see here. Actually, let's do Kathy. Hey, Kathy, how are you?
Hi.
Good. So what case list would you like to do?
I don't have a preference, but I guess just for variety tonight, why don't we do GYN?
All right. Do you have a particular case that you would like to cover or not necessarily?
No, I just maybe feel like it's a little bit on my weaker side, so.
All righty. Oh boy, this is every night one of these doesn't load all the way. It's ridiculous. And this one is, let me see here if it's give it a little bit more time. Is it gonna load? No. Let me see, let me go out. And let me just click on the OB one just to see if this one's gonna load all the cases. Look at that. We're stopping with Hannah. Hannah, you're wrecking everything. Isn't that weird? I might have to go back to office and see if we can find you in here. Yeah, look at this one's. Did I go past you yet? No. Oh, there you are. Is this going to be you here? I wonder. Then they just put it under Lee.
I don't know.
Let's just go with it. Yeah.
Okay.
I guess we're gonna make this an office night because this is the only one for whatever reason is loading. No, that's a different Lee. Here you are, right?
Yep.
Okay. All right. Let's just go. This is the one everybody hates, so come on, you'll do it. Patient number 2, 61-year-old, well woman exam. What screening are you going to do on her?
So as far as screening, it would be pap smear screen for cervical cancer screening, breast cancer screening with a mammogram. We would talk about colon cancer screening with colonoscopy, and bone density with a DEXA.
You would get she's 61, so you would do why would you do a DEXA scan on her?
We would talk about if we had any risk factors for it. Not necessarily that it'd be universal screening, but just if there is anything in her history that would point me towards doing a DEXA.
Such as what?
If she had any secondary issues like rheumatoid arthritis or SLE, if she'd been on steroids for a long time, if she's a lifetime smoker, if she has never taken calcium supplements her whole life or was pretty sedentary her whole life, if she's had a parent that had a history of a hip fracture, if she'd had any fractures in her lifetime.
Okay. So when would you routinely do a DEXA scan? I mean, when is everyone going to get one?
Universally recommended at age 65 and older.
Okay. And then, so if you're going to do it on someone younger than that, do you just say, wow, you've got a couple of risk factors, let's get it earlier, or do you use anything to help quantitate if they have enough risks to justify an earlier DEXA scan?
Mm-hmm. So in getting the history, the things I listed are part of the frax assessment tool. So
okay.
I basically frax.
So you would calculate it. Okay, so what would the value have to be in order for you to justify then getting an earlier DEXA scan?
That's a good question. I don't know that one. I have to look that up.
Okay. All right. Well, you know, it's not, if it's greater than 9.3%, why in the world would they pick that dumb of a number? You probably don't know, right?
I don't know.
And here's the reason is we recommend everyone get a DEXA scan at age 65. The 10-year fracture risk for the average 65-year-old woman is 9.3%.
Okay.
So if you have someone less than 65, but because they have enough risk factors, they calculate out at the exact same risk as a 65-year-old, you do their DEXA sooner. So it actually kind of makes sense. Okay, good. All right, so that's how you would use the frax for that. All right, we talked about let's see here. What else are you going to count? So you did a mammogram, you did her pap and cytology, talked to her about a colonoscopy. When do you start doing colonoscopies and how often should they get them if they're normal?
So typically to start at age 50, unless there's a family history of colon cancer, then it would be 10 years younger than the age of when the person had the colon cancer before age 50. Sorry, the other part of the question was?
I think how often should they get it?
How often if it was normal. So I typically counsel on getting a colonoscopy. So if it's normal, it's in 10 years to repeat the next colonoscopy screening, if normal.
Okay. What else are you going to talk to the 61-year-old about?
I would talk to her about calcium supplementation for osteoporosis prevention. Talk to her about falls risk, if she has anything in the house that could potentially cause her to fall, as well as I guess eyesight and smoking cessation. If she was smoking, I would talk to her about if there's any family history of cancers.
What about vaccines? What are you going to talk to her about vaccines?
As far as vaccines, we would review her vaccine history. At age 50, I would have asked if she had gotten her zoster at that time, her herpes zoster vaccine. And then as she's approaching age 65, we would be talking about her pneumococcal vaccine. And then that she should be getting her influenza vaccine annually still.
Okay. All right. So good. So here's what I'm going to help everybody here. And ACOG has, sometimes I wonder, okay, why do we even do well women exams when we're not? Should we be doing pelvic exams? Should we be doing breast exams? Should we be doing this? But then they just keep making what we're supposed to screen for bigger and bigger and bigger. All right. So if this is what I want you guys to think about, and I try to help everybody with this because the annual exam's a pain in the butt. So somebody comes in and they go, so tell me what you're going to screen for on a 17-year-old or a 61-year-old, etc. So I want you to say when it comes to screening, you break it into kind of two components. There's a history-based screening, and then there's an actual test-based screening. And the testing part that you do is really going to be age dependent and risk dependent, but everyone's going to get the same history-based screening. So ACOG says at every annual exam, we're supposed to screen for intimate partner violence, depression, substance abuse, update family history every year looking for the hereditary cancers such as breast, colon, uterine, and ovarian. And then I add in vaccines. So if you think about intimate partner violence, depression, family history update for hereditary cancer, substance abuse, and vaccines. So that's something we're going to ask them about at every annual exam. Then the testing based in a 61-year-old, you're right, you're going to do your cytology with co-testing. You're going to get annual mammograms. You're going to make sure she's up to date on her colonoscopy. You're going to get a DEXA scan earlier if she has enough risk factors and her frax score calculates out. And what about labs? What labs should a 61 have? Now, most of these patients have internists, but it's still reasonable for us to ask them, have you had X, Y, and Z done in the last year? So what labs would you want to know that a 61-year-old had?
Labs would be a hemoglobin A1C for diabetes, a thyroid TSH, a lipid panel to check her cholesterol, as well as a basic CBC CMP to just check her liver function and renal function.
Good. Absolutely great. The other thing then with regards to the wellness exam, since cardiovascular disease is what kills about half of us, ACOG says it's a good opportunity to just discuss and emphasize the importance of a heart healthy lifestyle. That's kind of with everyone. And then in addition, you're going to look at this patient. Okay, so everything you talked to her about would be the different things to help promote bone health, heart healthy lifestyle, and making sure she's up to date on her vaccines. So the well woman can be difficult, but that may help you to just organize it a little bit better.
Yeah. All right. That sounds good. Thank you.
Okay. Thanks, Kathy. All right. All right, Jennifer. Hey, Jennifer, how are you?
I'm good. How are you?
Good. All right. Let's just stay with office because I can get to them quicker, and office is a pain in the butt.
I think my OB was actually on there if you wanted to switch, but I am great with Office too.
Oh, yours. Oh, yeah, yours was. Well, okay, let me see here. Let's go ahead.
Just if you want to mix it up.
Sounds good. That's right, because you're a C, so you were early enough. Wait, why did they do that? All right. Do you have any particular case that you would like us to do?
I think any of them are fair game.
Okay. You don't
Maybe
have some
something towards the
horror
end.
case?
I do, but it
Okay,
seems
yeah,
to
I
be
know.
the same ones that everyone keeps asking. So
Okay, I gotcha. So let's just let this load. Come on, it's still loading. All right, so yeah, let's scroll toward the back because you're right. We tend to do the ones toward the front because in the interest of time, we're trying to quick grab something and go with that. And let's see here. Have you guys done this one? Have you done a hematoma recently, vaginal hematoma?
we have not.
Okay, let's do that one. Let's see here. Okay, here we go. All right, so you've had about a 27-year-old G5P1. She had a prior preterm delivery. So let's just talk about that real quickly. You've got listed what you did, but tell me what you did and why.
So in this patient, she had a prior preterm delivery at 26 weeks. She had spontaneously delivered, actually at work, with painless cervical dilation. So at the beginning of her prenatal care, we talked about early screening due to her excuse me, second trimester delivery with cervical length ultrasound starting at 14 weeks. Every 2 weeks, we were going to monitor her cervical length and then started her on the hydroxyprogesterone weekly injections at 16 weeks was the plan for her. So we
Okay,
continued her cervical lengths until 24 weeks.
Okay, and when she had her prior preterm, do you remember what was the gestational age?
It was like 26 weeks and like 3 or 4 days. So she was very, very
real
early.
young. Okay, all
Yeah.
right. So tell me what cervical length finding would have made you recommend some sort of an intervention?
So generally we would have considered a cerclage if her cervical length was less than 25 millimeters.
Okay, perfect. All right. She also had chronic hypertension. So what did you talk to her about the risk of chronic hypertension in pregnancy?
So with her chronic hypertension, we talked about sort of the blood pressure changes that tend to happen during pregnancy, excuse me, with the decrease in the first and second trimester and then the increasing blood pressures later on in the third. We talked about her risk of preeclampsia in pregnancy and starting her on baby aspirin at, generally we shoot for about 12 weeks, but sometimes we're not seeing them until a few weeks after that. So between 12 and 28 weeks is the recommendation. Because of her risk of preeclampsia, we talked about getting some baseline preeclampsia labs so that we would have something to compare it to later on in pregnancy. We also talked to her about her increased antenatal surveillance. She was getting that for a couple of reasons, you know, her chronic hypertension and her obesity, and then her prior preterm delivery. So more frequent growth ultrasound starting in the third trimester, and then twice weekly non-stress tests starting at 32 weeks. And then continued blood pressure monitoring throughout her pregnancy with medication, either initiation or adjustments as needed.
Was she on any meds or for hypertensive tension during her antenatal care?
She was not. So she
Okay.
was in that, like, the guidelines changed in between her care. So she was in that like high 130s to 140s over 80s range. So she was not on meds in between her pregnancies. And we decided just
Okay.
to monitor her closely.
Okay, perfect. So anyway, so great. So she was on aspirin because all chronic hypertensions get put on aspirin to reduce the risk of preeclampsia. So you talked about her risk being primarily increased risk of preeclampsia, but what else? What are some of the other risks? I mean, you discuss proper management, but what are some other things you would just tell her about?
So we would also talk to her about her risk of fetal growth abnormalities due to some of the placental insufficiency that can happen with hypertensives. We'd also talk to her about the importance of maintaining normotensive blood pressures just to help improve fetal status because she is at risk of fetal demise with her hypertension.
And then probably the only other thing I can think of is increased risk of abruption.
Okay.
with chronic hypertension. So the biggest ones so another thing too is anytime they say to you, so what's the increased risk of chronic hypertension in pregnancy? It's always great to say, I think about maternal risks and fetal risk. And so then with the maternal risk, it would be increased risk of, maybe worsening of her blood pressure. If she's only 27, but if she was 37, maybe worsening of what already has some end organ hypertensive damage like kidney functions, etc. Increased risk of stroke, etc. And then I never know if an abruption is a maternal risk or a fetal risk, but because it
Right.
affects both. It's like, which one is that worse for? But then with regards to the fetal risk, of course, the biggest ones are risk of IUFD and, growth restriction, etc. So, but I mean, you're doing great, absolutely great. I'm just trying to help you with that. All right, so then you go ahead and you induce her at 38 and 2. Tell me when you discovered this vaginal hematoma.
So the vaginal hematoma was discovered after, she had a small first-degree laceration on the right side of her vagina, which we repaired because it was bleeding. And as we were cleaning the patient, getting ready to put her bed back together and such, that's when we discovered that she had this small hematoma on her left vaginal side wall. At that point, we just decided to monitor the hematoma while we were in the room. It appeared to be, excuse me, non-expanding. It was non-tender. It was about 2.5 centimeters in size. So we talked to her about applying pressure and ice packs, and the nurses continuing to monitor it while she was on labor and delivery, and then notifying the postpartum of the presence of the hematoma and, to notify us of any changes.
Perfect. So what's the significance of, and why do we worry more about vaginal hematomas than vulvar hematomas?
So we worry more about vaginal hematomas because they tend to be more likely to expand. They're not in a confined space like a vulvar hematoma is. And so they're more likely to be larger in size, cause more pain, have pretty significant retroperitoneal bleeding, and I guess hematoma formation.
Exactly. So if let's say this was larger than that and you couldn't really, it was higher up in the vagina and larger, maybe she had a precipitous delivery or you had to put forceps or, something like that, you had a higher up in the vaginal wall hematoma, how would you follow it to make sure it was stable and not expanding?
That part becomes tricky because that's not something that the nurses would be able to monitor the size of. So we could, in theory, pack the vagina to apply some pressure on the area. We could do serial CBCs. She obviously is getting, regular vital signs, but we could make sure that they were doing her vitals every hour to make sure that we weren't having any hemodynamic changes from the blood loss. Those are some of the things I can think of.
Yep, that's exactly right. And then if the crit was dropping, then you would do some sort of imaging, most likely a CAT scan, to see if you truly could see any sort of a significant retroperitoneal bleed. All right.
Right.
Well, great. All right. So I think you did great because, yeah, I have nothing else to add.
Nice.
So
Cool. Thank you.
good job. Okay. All right, Jennifer. Thank you.
Thanks.
All right, thanks. All right, I'm going to quickly lower everyone's hand. Any last minute questions or comments? All right, let me just quick scroll through here. I appreciate, oops, Danielle. Hey, Danielle. Oops, you're muted on your end, Danielle. Oops, there we go. Hang on. There you go. Oh, why? You're muted on your end again. Okay, are you there? I don't know why I'm not able to unmute you. Attendee is self-muted and muted by me. Now you're just self-muted. Hit your mute button again. Kate, are you there? Danielle? Oh, well, I'm sorry, Danielle. We'll have to maybe email me a question. Caitlin, did you have a question or comment?
Hello? Yeah.
Yeah, did you have a
Just a quick question. So I
Mhm.
did change the person that I was following, our first case that we talked about. I started the patch like right away, but would it make more sense to have waited until the labs were back to make sure that she was actually menopausal before I started her
No,
on the
no,
HRT, or does it really not
no,
matter?
no, no, because you know what? If she came in at 46 with just kind of skipping periods and having horrible vasomotor symptoms, you'd start her on the patch, right? I mean, or you would start her on
Right,
hormones if she came in
right.
symptomatic. So
I just didn't know
I
if
don't
they,
no, I don't have any problem with that. She came in on pills,
okay.
horribly symptomatic. You're like, if it walks like a duck and quacks like a duck, it's a duck. You're like, this patient is menopausal with severe symptoms until proven otherwise. I'm getting labs to make sure it's not due to hyperthyroidism or something else going on. But in the meantime, no harm is caused by putting her on an estrogen patch to see if it gives her some symptom relief. Okay?
Okay. Thank
All
you.
right. Uh-huh.
Mhm.
Hey, Maria.
Hi, how are you?
Question?
So I have a question. So I was reading the osteoporosis practice bulletin, and in the bulletin it says that you can give estrogen for treatment, for prevention. Wait, is it treatment or prevention? I don't remember exactly what it says.
Prevention. Mm-hmm.
Prevention, okay, but we're not supposed to say that we give estrogen for prevention of osteoporosis. It's just supposed to be for the treatment of vasomotor symptoms. You know what I mean? So I guess
I totally know what you're saying. So here's the thing. When it comes to osteoporosis, I believe it actually has an FDA approved indication for the prevention of osteoporosis. So they're really more talking about it has an indication. We know estrogen can treat osteoporosis, but it's not FDA approved for that indication. Does that
oh,
kind of make sense?
it kind of does. My question is, if I don't want to get tripped up on the exam, if they ask me, well, would you give estrogen for the treatment of osteoporosis?
Here's what you say. The estrogen therapy is not first line treatment for osteoporosis at all. First line treatment would be the bisphosphonates or the rank ligand inhibitors.
Mhm.
Those are first line for that. The only time you would ever consider giving estrogen for osteoporosis if the patient had contraindications or could not tolerate every other medication for osteoporosis out there and you had nothing else left to go to, then you could consider putting her on estrogen or a serum, like a
Oh,
raloxifene or something.
or something like that. What if they ask me, do I ever put them on estrogen for prevention of osteoporosis, which is not something I
No,
really ever do in
you don't.
practice?
What's
Yeah,
the indication for hormone therapy? What's the approved indication?
vasomotor symptoms.
Correct. The only reason we're supposed to put patients on hormone replacement therapy is for the treatment of moderate to severe vasomotor symptoms. We're not supposed to give it for prevention of anything.
Okay, it just confused me when I saw that box and it said that you could give estrogen for prevention. I was like, I don't know how I should approach that in the exam, so
Yeah,
I just wanted
yeah.
to ask.
So that's how I would do it. If they said, would you give it for prevention? Say no. The indication for hormone replacement therapy is the treatment to moderate to severe vasomotor symptoms. If they indeed have that, I could certainly discuss with them that this will help prevent their osteoporosis, but I would never just give it for that.
Okay, perfect. And then I'm sorry, I have one other quick question just from the first case about the estradiol. So also in my practice, I routinely don't ever really order estradiol unless I'm really concerned about primary ovarian insufficiency. But throughout the
Agree.
webinars, I just, sometimes I see it thrown in the labs like PCOS or, other random indications, but I just want to make sure that it's there are no other indications that I'm missing, and that it's kind of just a
Well,
preference
I
thing.
guess a secondary, primary or secondary amenorrhea, because if
Right.
somebody had secondary amenorrhea and you didn't know why, and you got a FSH that was elevated, you don't know if it's premature ovarian insufficiency or hypothalamic pituitary ovarian failure or access. So that would be an indication. I agree with you. I don't see any reason to check an estradiol level on somebody who's having hot flashes, etc. Does that
Okay.
kind of answer? Yeah.
Yep. And
Yeah,
then
a
for
lot of
PCOS,
people
I
will
don't need
check
to
them.
either, right? I'm sorry, I didn't mean to interrupt you.
With PCOS, in order to make a diagnosis of PCOS, you have to rule out other causes first, right? So
Right.
if I did a okay, so somebody come in to see me who's obese, has some hirsutism, hasn't had a menses in 8 months, I'm still going to check an FSH, a TSH, and a prolactin to rule out other causes of secondary amenorrhea. But I'm not going to get an estradiol level on that lady. I might get it second line if nothing was adding up.
Okay, great, because that's what I do too. So I just wanted to make sure that it wasn't that I was supposed to get an estradiol on other patients aside from those indications.
Yep, no, that makes sense.
Okay, all right, thank you
All
so
right.
much.
Uh-huh. All right, good. All right, guys, let's call it a night. I'll be back Wednesday the 13th with some structured cases. All right, bye-bye.